Hello friends. So yeah, we'll begin with the MCQs, and yeah, it's basically the question is it's a opthal question here. So yeah, it's a 70-year-old patient presents with progressive deterioration of vision, and on examination the pupillary reaction is sluggish and the IOP is elevated. Yeah, okay, they are joining. Okay, I'll just I'll just repeat the question. It's a 70-year-old patient who has a progressive deterioration of vision, and on examination you see there is a pupillary reaction which is sluggish and IOP is elevated. So yeah, fundoscopy shows a large deep cup and the visual field reveals a paracentral scotoma. So what is the first line of treatment here? And the options are timolol, pilocarpine, epinephrine, or it's a carbonic anhydrase inhibitor. So basically yeah, it's a opthal question. So basically they are asking about I will again repeat, it's a 70-year-old progressive deterioration of vision, and on examination there is a pupillary reaction is sluggish and IOP is elevated. So you do a fundoscopy. In fundoscopy you see there is a large and deep cup and the visual field reveals a paracentral scotoma. So what is the first line of treatment for this diagnosis? And the options are timolol, pilocarpine, epinephrine, or it's a carbonic anhydrase inhibitor. So basically it's a from the whatever they have given in the clinical scenario, you can just tell it is a case of anyone. Yeah, it's a case of open angle glaucoma. So yeah, now you can tell what is the drug of choice for open angle glaucoma, and the options are timolol, pilocarpine, epinephrine, or it's a carbonic anhydrase inhibitor. So yeah, what is the drug of choice for primary open angle glaucoma? Anyone? Timolol, pilocarpine, epinephrine, or it's a carbonic anhydrase inhibitor. So yeah, okay, the answer here is normally it should be, they have not given actually, it should be actually prostaglandin analogs should be there, but yeah, from the options the answer is timolol. So yeah, timolol, that is a beta blocker. So timolol is given for the condition of primary open angle glaucoma. So yeah, but the drug of choice for is prostaglandin analogs. Before you used to give beta blockers. So next we have it's OBG question. Yeah, next we have a distraught woman comes to the casualty at 18 weeks of gestation with complaints of vaginal bleeding. So she has a history of 2 early pregnancy loss. So USG reveals the absence of fetal cardiac activity. So which of the following investigation need not be done in the patient? So yeah, I will just repeat the question. The question here is, it's a woman who comes to casualty with at 18 weeks of gestation with complaints of vaginal bleeding. So she has a history of already 2 pregnancy loss, and the USG reveals that there is an absence of cardiac activity, fetal cardiac activity is absent. So which of the following, basically they are asking which of the following condition you will not use for a recurrent abortion case. The options are extensive infection workup, serum prolactin level, it's a saline infusion sonography, or parental karyotyping. Anyone? I'll just repeat, it's a extensive infection workup, serum prolactin level, saline infusion sonography, or it's a parental karyotyping. So yeah, anyone wants to learn to answer this? Okay, the answer here is for a recurrent abortion we generally don't do an infection workup, because infection workup we can do, but basically there is only one condition in which there will be an infection which will be causing basically abortions, and that is syphilis. So yeah, sorry for that. So yeah, where I was, it was basically in syphilis only there is a recurrent abortion, otherwise we don't do infection workup for that. So yeah, that was serum prolactin level we check, saline infusion we do. So basically depending on the cause we check the for which type of abortion, what is the cause for the abortion. So yeah, so for genetic you do karyotyping, for anatomic you do 3D ultrasound and all that, endocrine or infection is not there. So yeah, next question we have, I don't know. Okay, next we have in a patient with critical limb ischemia, what is the ankle brachial pressure index likely to be? I will repeat, in a patient with, it's a critical limb ischemia patient, and what is the ankle brachial pressure index? So yeah, and the options are less than 0.1, less than 0.3, or it's a less than 0.5, or it's a less than 0.9. So yeah, if you can tell the answer. Anyone? You have to remember it's a factual question and it's a patient with critical limb ischemia. So what is the ankle brachial pressure index likely to be? Less than 0.1, 0.3, 0.5, or 0.9. Anyone can at least answer this if you don't know the answer. C. No, it's not C, it's a B. That is less than 0.3 is the right answer. So yeah, basically there is a full interpretation, there is a classification of the interpretation, and it's like 0.91 to 1 less than 1.3 is normal, and less than 0.9 is occlusive arterial disease, and 0.5 to 0.9 is obstruction, 0.5 is respin, and that is 0.3. So your answer here is 0.3. In 0.3 you can tell it's a critical limb ischemia. So yeah, it's a 0.3 is the right answer for this ankle branchial index. Next question we have, what are rotationally unstable but vertically stable pelvic ring fracture? So it's a orthopedic question. I will just repeat. What are rotationally unstable but vertically stable pelvic ring fractures classified as title type B, type C, knee type 1, or it's a knee type 2? So I also don't know this, but yeah, I can also try. So I will just repeat. What are rotationally unstable but vertically stable pelvic ring classified as tile type B, tile type C, or it's a knee type 1, or it's a knee type 2? Anyone? Just guess it out. I also don't know the answer. I'm not a teacher, I am just like you only. So yeah, there are two classifications, that is tile classification, knee classification, which we are talking about. Anyone wants to answer? So okay, I will just tell the answer. The answer here is, that is, it's a tile type B answer. So your type B is rotationally unstable and vertically stable. So yeah, you have to remember. I will also remember all this. So type classification is basically, if say it's a type A, B, or C. So if you have a type A, it is rotationally and vertically stable, and it's a type B, rotationally unstable and vertically stable, or you can have a type C, that is rotationally and vertically unstable. So yeah, and knee classification, what they have given is for proximal humor fracture, not for this condition which we are talking about. So if it's a pelvic fracture, you consider it's a tile classification, or whether it's a humerus fracture, you consider as a knee classification. Next question we have, which of the following fascia attaches the perirenal fascia to the peritoneum? I repeat, which of the following fascia attaches the perirenal fascia to the peritoneum? And the options are Gerota's fascia, lateroconal fascia, thoracolumbar fascia, or it's a Treitz fascia. So anyone wants to answer which of the following fascia, and it's an anatomic question, which of the following fascia attaches the perianal fascia to the peritoneum? Gerota's fascia, lateral conal fascia, thoracolumbar fascia, or it's a Treitz fascia? Anyone? Guess it out. No one will tell. I am not a teacher, I am not a... If you can tell. Anyone? Okay, so basically it's a factual question. You have to remember that there is no choice. Yeah, the answer is B. That is lateroconal fascia is the right answer. In lateroconal fascia, basically it attaches the perirenal fascia to the peritoneum. So yeah, you have to remember that there is no choice for you also. And yeah, see, the options were Gerota's fascia. In Gerota's fascia is basically it's a perirenal fascia, and thoracolumbar is a multiple facial layers of the thoracolumbar region, and the last option was Treitz fascia, and that is basically, it refers to the fusion fascia behind the head of the pancreas. So yeah, the only answer here is lateroconal fascia, which will attach the perirenal fascia to the peritoneum. So yeah. Next question we have, it's a 60-year-old woman with fever and splenomegaly, and she was diagnosed to have a CML. So she was started on imatinib therapy. After a few months of therapy, she had persistent progressive splenomegaly and fatigue. So which of the following will not be seen in this phase? So yeah, so this question is also very repeated question. CML, CLL, both the questions are very repeated. So yeah, which of the following will not be seen in this phase? And the options are greater than 20% blast in blood or marrow, greater than 20% basophils in blood, or it's a platelet count less than 100 into 10 to the power 9 per liter, or it's a WBC count greater than 10 into 100 to the power 9 per liter. So yeah, this is you have to tell which of the following is not seen. So yeah, I will just tell it's a case of CML, fever, splenomegaly is there. After a few months of therapy, she had persistent progressive splenomegaly and fatigue. So which of the following will not be seen? So anyone? You can just tell what is the phase. You know, in CML we have phases, like you have static phase, I think it's an accelerated phase. Yeah. So yeah, in this case we have a progressive splenomegaly and not responsive to therapy. It's suggestive of a accelerated phase. So yeah, in a accelerated phase, blast size will be less than 20%, not more than 20% blood or marrow. So you have to remember this. It's a diagnosis of accelerated phase of CML requires one of the following criteria, and all that I told. It should be greater than 20% basophil should be there, and platelet count should be less than 100 into 10 to the power 9 per liter, and WBC should be greater than 10 into 10 to the power 9 per liter. So yeah, only thing you have to remember, there should be less than 20% in blood or marrow in CML if it's an accelerated case. So yeah, am I going too fast or it's okay? I think. Okay, next we have, this is also repeated one. See, ABG is also very repeated. In ABG they will ask, every time they ask ABG questions, ABG and sometimes ECG. Yeah. So next we have, it's a young asthmatic boy who was rushed to the emergency, that is ED, with confusion and gasping of breath. So his ABG analysis is as shown. So what is the acid base disorder? Options: pH is 7.25, PCO2 is 70, HCO3 is 26, and its PO2 is 45. So you have to tell from this what is the condition, that is it's a respiratory alkalosis and compensated, it's a respiratory acidosis partially compensated, or it's a respiratory acidosis and fully compensated, or it's a metabolic acidosis and uncompensated. So yeah, anyone wants to answer? Its pH is 7.25, PCO2 is 70, HCO3 is 26, and PO2 is 45. So yeah, confusion and gasping of breath. Today I think no one wants to answer, I think. I am too early for today, yeah. Anyone? See, ABG is also very that much. If you want to answer this. Okay, the answer here is, that is B. It's a case of respiratory acidosis, sorry. It's a case of respiratory acidosis and that is partially compensated. Basically, see, if you have a confusion, gasping of breath, there are many conditions gasping of breath. But yeah, in emergency you can find condition like COPD, there will be acute exacerbation. It's asthma also you will get in emergency room. So yeah, in this case pH is 7.25, PCO2 is 70, HCO3 is 26, and PO2 is 45. So yeah, see, the pH is 7.25, so it is decreased. Normally it is around 7 point something it is, I don't remember. So yeah, it's okay, the pH is decreased here, so it's a case of acidosis, that's confirmed. Then we have PCO2. See, PCO2 is normally 40, yeah, it's 40. So here they have given 70, so it has been increased. So if PCO2 is increased, so you can tell it's a case of it's a respiratory acidosis because PCO2 is increased. And then we had HCO3, that is HCO3 is 26. So and normally it's a normal HCO3 is 24. So that is 26 minus 24 is 2. Basically there is a compensation, that means there is a compensation in this. Yeah. So yeah, basically yeah, it's a respiratory acidosis and there is a partially compensated because HCO3 is increased, that is it's 26, normal should be 24. So yeah. So yeah, ABG you have to remember, because ABG one question I know every time it comes. Not ever, I have not given many exams, but yeah, ABG is quite common. So yeah, next we have, it's a 2-month-old infant and he was brought by the mother due to irritability and seizures. On examination, bulging frontanels and macrocephaly were noted. So CT scan is given here. I will just tell what it is. I'll just repeat for the last time. It's a 2-month-old infant brought by the mother due to irritability and seizures. So on examination, bulging frontanels and macrocephaly were noted. So CT showed the following findings. So what is the likely diagnosis? And the options are Dandy-Walker malformation, Arnold-Chiari malformation, vein of Galen malformation, or it's a Daubert syndrome. So I'll just tell what is there in the CT scan. They given the CT. So it shows there is a large cystic area which occupies the posterior, that is the posterior, you can say, yeah, it's a posterior fourth ventricle, that is the posterior part of the brain it occupies. So yeah, it's a large cystic area occupying the posterior aspect of the posterior fossa and it's committed to directly to the fourth ventricle. So yeah, basically now you can just tell what is the diagnosis. I will repeat, its options are Dandy-Walker malformation, Arnold-Chiari malformation, vein of Galen malformation, or it's Daubert syndrome. Anyone? Okay, no one. So yeah, it's see, when you have a irritability or seizures, you can think there is a stroke. Normally we think there is a if there is a RTA, basically if there is a RTA within stroke, but yeah, it's already it's a 2-month-old infant, and that too irritable and seizures. If it's a seizures, you know there is some CNS problem, so you go for CT scan normally also. And bulging frontinels and macrocephaly was there in this case also. So yeah, it's a CT scan, and you see there is a posterior part that is a cystic area is there. So yeah, the answer is Dandy-Walker malformation. So it's a very characteristic that in Dandy-Walker malformation, the posterior part of the brain will be occupied, that is the cystic area will be there, and there will be macrocephaly and all that features will be there. So yeah, it's a Dandy-Walker malformation. It's an anomaly. Next we have, yeah, it's X-ray again. It's again, I think it's a neonate, no, it's a child, yeah. Now it is a 3-day-old neonate who presents with abdominal distension and bilious vomiting. So an erect X-ray was taken as shown below. So the neonate is taken up for surgery, and an apple peel bowel with loss of dorsal mesentery is seen. So which of the ileal atresia has this feature? So yeah, I will repeat, it's a 3-day-old neonate who presents with abdominal distension and bilious vomiting is there. So an erect X-ray you do, it is basically then you take the neonate for the surgery, and an apple. I think the net is there or not? Am I audible? Yeah, it's there. So yeah, which type of ileal atresia is shown in this feature? That is type 1, type 2, type 3 and type 4. Okay. Basically I will just tell it is a X-ray. It's a jejunal atresia basically, yeah. Jejunal atresia is seen in Galen. I think you are there in the last question only. Galen. No, it's not. It was not Galen. It was basically Dandy-Walker malformation. So yeah, this question, it is a different question. So yeah, it's basically you have to remember there is an apple peel bowel with loss of dorsal mesentery seen in which condition. It's a ileal atresia they have already given. Basically which type in classification you have to tell which type it is, 1, 2, 3 or 4. So yeah, the answer is, if you know the answer, if you know the classification of atresia. Okay, I will just tell it's a type 3. See, in ileojejunal atresia, it's a case of ileal atresia, or yeah, it's a case of ileal atresia. So what you are saying what I said, it is a apple peel bowel with loss of dorsal mesentery seen in this condition. So yeah, it's a type 3 in classification. We have the classification that is from 1 to 4. So I'll just go to your classification. From 1 it is basically mucosal web or diaphragm. 2 is with an atretic cord between the two blind ends of bowel with intact mesentery, or it's a type 3A or type 3B. We are talking about here is type 3B, that is an apple peel or a Christmas tree deformity with a large mesenteric gap. There was one Christmas tree in that also, in opthal also you have a Christmas tree. I don't remember right now, but yeah. So yeah, it's a type 3, that is an apple peel or a Christmas tree deformity with a large mesenteric gap. So it is seen in which condition? It's a ileal atresia. Yeah. Next we have, it's a detectable taste begins to appear in drinking water if chloride level is exceed basically, yeah. So it's a PSM question, and it tells that it's you detect a taste which begins to appear in drinking water if chloride level exceeded what? Basically when the chloride level exceeds, they are telling it's a 150 mg per liter, 200, 250 or it's a 300 mg per liter. So yeah, anyone wants to answer? When does you get? It's getting paused, I think, again. Am I audible? Yes or no? At least you can tell. Yes, the net is there. So yeah, where I was, it's a taste is there which basically there is a detectable taste begins to appear in drinking water if the chloride level exceeds. So yeah, the answer is 250. You have to remember this. If there is a 250 mg per liter that is in the chloride level, so there will be a taste difference in the drinking water. So there is a WHO guidelines, and you know it's basically taste, color and all that they will tell. So yeah, next we have a 16-year-old boy is admitted with fever, icterus, conjunctival suffocation and hematuria for 15 days. So which serological test should be done for diagnosis? And the options are White test, microscopic agglutination test, Wheel-Phillips reaction, or it's a Paul Bunner test. So yeah, I repeat, it's a 16-year-old boy. He is admitted for fever, iterus, conjunctival suppuration and hematuria for 15 days. So which serological test would you do for this diagnosis? And Widal test, microscopic agglutination test, Wheel Phillips, or it's a Paul Bunner. So tell what is the diagnosis only. They leave about the investigation of choice and all that. Just tell me what is the diagnosis, what you think. What is the differential diagnosis you think in the case of 16-year-old boy, fever, iterus, conjunctival suppuration and hematuria for 15 days. So when a patient comes to you, what will you diagnose? Anyone? Okay. At least please tell that all. Okay, don't want to tell. Okay, yeah, it's a case of, okay, I will just tell what is the diagnosis, then you can tell. It's a, okay, you won't be able to tell, I know. It's a okay. The diagnosis is basically here is, it's a leptospirosis. So when you have a patient with all this fever, conjunctival suppuration is basically a diagnosis for, not diagnosis, it goes to a leptospirosis and hematuria is there, that's what. So yeah. So we do which serological test we do? That is, we do a microscopic agglutination test we do here. So you have to remember that only. So in leptospirosis, that is a Weil's disease we know. So yeah, Widal, see next options we have Widal test. So Widal test, it's for typhoid. Then Wheel Phillips, it's for rickettsia. Then there was a Paul Bunner test. So yeah, Paul Bunner is for infectious mononucleosis. So yeah, the answer right here answer is microscopic agglutination test is the right answer. Next we have, which of the following features would you not expect to see in patient with Parkinson disease? Yeah, it's a easy one I think. I will repeat, it's which of the following would you not expect to see in a patient with Parkinson disease? And the options are genitourinary disturbance, orthostatic hypotension, exaggerated deep tendon reflex, or it's a micrographia. Anyone? This at least I think you can tell, please. Okay, if you cannot, there is no option. So yeah, which do not expect, which of the following you do not expect in Parkinson disease? Genitourinary disturbance, orthostatic hypotension, it's an exaggerated deep tendon reflex, or a micrographia. So yeah. See, in Parkinsonism, there will be writing will be small, micrographia will be there. Then genitourinary disturbance, it happens because constipation is most common. Constipation is seen mostly in Parkinson. And yeah, orthostatic hypotension is also seen because even we have seen besides postural instability because of that. So yeah, we know it's a tremors, rigidity, and dyskinesia. It's a bradykinesia, akinesia, and postural instability. So yeah, the right answer is which of the following which you do not expect is exaggerated deep tendon reflex. So yeah, and Parkinson, it's a degenerative disorder. So no need to tell all that again. Today I think no one wants any response. Yeah, okay, next we have, it's a pathology question. It's a 2-year-old girl was brought to the hospital by her mother with complaints of abdominal pain and diarrhea. So yeah, the patient is coming to you with abdominal pain and diarrhea, and on examination you find there is a palpable mass. See, orthostatic hypotension, yeah. Orthostatic hypotension is there. Orthostatic hypotension will be there in Parkinson. What will not there in Parkinson is exaggerated deep tendon reflex. So because of postural instability, it went off. I think it's falling off. Today I think everything is falling. Yeah. So yeah, it's orthostatic hypotension is a wrong answer. Exaggerated deep tendon reflex is the right answer. So yeah, where I was, it's a 2-year-old girl, and her mother complains of abdominal pain and diarrhea. So you do examination and you review that there is a palpable abdominal mass, and investigation you find there is a elevated levels of urinary homophilic. Which language are you speaking? I think you are from Williams, Florida. I am speaking English only, I think. It's an Indian English. So yeah, it's where I was. Yeah, examination reveals a palpable abdominal mass. Investigation shows elevated levels of urinary homovanillic acid and vanillyl mandelic acid. The lesion could not be completely dissected during surgery, and the histological findings are given below. So which of the following is a monoclonal antibody approved for use in this condition? So it's alirocumab, motrozumab, dinutuximab, or it's a denosumab. So yeah, I will just tell, I also don't this, I will just tell what is the diagnosis here, because I am also very confused in this. I will just tell it's a 2-year-old, and abdominal pain, diarrhea, palpable abdominal mass, increased level of urinary homovanillic acid and vanillyl metallic acid, and a lesion cannot be completely resected during surgery, and histopathological finding is given below. And yeah, there was a humor right pseudorosets in the histological finding. So yeah, basically here the diagnosis is a pediatric neuroblastoma. So I also didn't knew that. It's a case of neuroblastoma. It's a pediatric neuroblastoma, and what you see in pathology, it's neuroblastoma. That see in pathology, what you are seeing here is there is a humor right pseudorosets. So yeah, and the answer which of the following is a monoclonal antibody approved for use in this condition is dinutuximab. Yeah, it's C. So yeah, I think today it's 1 minute. It's falling again and again. So yeah, next we have the audiogram of a patient who presented with gradually progressive hearing loss is given below. Which among the following would be the most likely diagnosis? So yeah, audiogram is there. I cannot just show you the audiogram here. So I'll just tell what is the case here. The case here is basically it's a case of Mania disease. So yeah, if you can tell what is Mania disease, if anyone, it's a ENT. Basically it shows an upsloping or ascending curve, basically suggesting that the lower frequency are affected first. And in proboscis we saw there is a downsloping in the audiogram. So if there is a upsloping or ascending curve in the audiogram, it's a Mania disease. And Mania disease, it's basically in ENT you learn Manias only every time, wherever. So yeah, next we have, sorry for all that, what is happening there. So yeah, next we have which of the following is correct regarding metformin. So yeah, I will just check metformin. So which of the following is correct regarding metformin? And the options are causes little or no hypoglycemia in non-diabetic patients, acts by increased insulin secretion, or it increases peripheral utilization of glucose and decreases absorption of glucose from the intestine, or it increases intake of calcium, may prevent metformin induced B12 absorption. So yeah, metformin, it's an anti-diabetic agent. So yeah, which of the following is not correct? The options were it causes little or no hypoglycemia in non-diabetic patients, it acts by increased insulin secretion, then we have it increases peripheral utilization of glucose and decreases absorption of glucose from the intestine, or it's increased intake of calcium, may prevent metformin induced B12 malabsorption. Anyone wants to try what is metformin? You know what is metformin, but just tell me what is the mechanism of action for metformin, if you know. It's a bygone idea. Okay, I will just tell. It's basically it acts by. Basically they have given it acts by increased insulin secretion. No, it's not insulin. It doesn't increase insulin secretion. Basically, it's decreases the insulin resistance. So yeah, it increases the peripheral utilization of glucose and it decreases the insulin resistance. So yeah, and the option A was it will cause a little or no hypoglycemia. It will cause, it's anti-diabetic, so it will cause hypoglycemia. Then there was increases peripheral utilization of glucose, that is a mechanism what I told, and it will be increased intake of calcium, may prevent metformin induced B12 absorption. So yeah, because metformin basically it interferes with the calcium. So yeah, if it interferes with the calcium absorption, so there will be malabsorption of B12. Yeah, calcium dependent B12 absorption. So yeah, next we have, it's a OBD question. So next we have, it's a G2P1 woman. I'll repeat, it's a G2P1 woman presents to the casualty at 30 weeks with a history of self-limiting painless bleeding PV 3 hours ago. So on examination, BP is 110/70 and pulse rate is 80 beats per minute. So what is the next best step for management? And the options are, I'll just repeat the question. If you can just tell diagnosis, that's enough for me. It's a G2P1, 30 weeks of that is period of gestation, and history of self-limiting painless bleeding PV 3 hours ago. On examination, BP is low, that is 110/70, PR is 80. So what is the next best step of management? Options are transvaginal ultrasound to confirm the diagnosis, start injection corticosteroids for fetal lung maturity, or it's a immediate LSCS, or it's expected management till 37 weeks. So yeah, anyone get to what a diagnosis here? G2P1 30 weeks and self-limiting painless PV, that is 3 hours ago, and BP low, PR also 80 is there, BP 110/70. Anyone? What is the case? If it's a 30 weeks of just tell me when do you have a painless bleeding after in 30 weeks you can tell. Today after 28 weeks, third trimester bleeding, if anyone can tell. Okay, it's a placenta previa. So yeah, in third trimester bleeding, if it is there is after 28 weeks, that there will be placenta previa will be there, or abruptive placenta will also be there. So yeah, so it's a case of placenta previa which we are talking about here. So yeah, so for diagnosis you have to confirm there is a transvaginal ultrasound. So transvaginal ultrasound will confirm a diagnosis first at this condition. If there is a patient comes to it with hypotension, bleeding, and that to 3 hours ago, if it is 30 weeks. So yeah. Next we have, it's a 58-year-old man with cervical lymphadenopathy, threatened abortion. Yeah. So yeah, 58-year-old man comes to you with cervical lymphadenopathy and is suspected to have chronic lymphocytic leukemia. So what should be the absolute lymphocyte count per millimeter to diagnose this condition? And the options are greater than 2000, greater than 5000, greater than 10,000, or it's greater than 1 lakh. So yeah, I will repeat. It's a 58-year-old man with cervical lymphadenopathy is suspected to have a CLL, that is chronic lymphocytic leukemia. So what should be the absolute lymphocyte count to diagnose this condition? Greater than 2000, 5000, 10,000, or 1 lakh. So yeah, if you can tell the answer for CLL, how much lymphocyte count should be there for CLL? Yeah, CLL is the most common leukemia of adults in the Western world. Okay. So yeah, the answer is, so you have to remember this. It's there is a lymphocyte count greater than 5,000. So you can suspect it as a CLL. But you have to correlate with the clinical features. And clinical features will be in any leukemia. It will be lymphadenopathy will be there. Cervical lymphadenopathy, yeah, it will be there. So diagnostic value is greater than 5,000. Next we have which metallic poisoning causes proximal, that is PCT damage with proteinuria and muscle pain. And the options are arsenic, chromium, mercury, lead. So I repeat, which metallic poisoning causes PCT damage, that is proximal convoluted tubule, as you know, it's damage with proteinuria and muscle pain. So the options are arsenic, chromium, mercury, or lead. Anyone can try this. So PCT damage with proteinuria and muscle pain, which poisoning it is? Okay, anyone wants to answer this? Okay, yeah, the answer there is that is arsenic. So in arsenic poisoning, see, in other damage you will see proteinuria and all that, you will see in other also. But yeah, if you have a case with muscle pain, so remember it's a arsenic. It's a diagnostic feature for that. So if it's a muscle, yeah, 5,000 was the right answer. So yeah, in this case, if it's a arsenic, in arsenic poisoning only you will have a muscle pain. So you have to remember, see, nephropathy is caused by most of the heavy metals, but however, muscle pain is just seen in arsenic poisoning only. Not only, you can see in other conditions, but yeah. Next question we have, a chronic alcoholic is there who is motivated to quit drinking, is prescribed disulfiram by his physician. So which of the following was employed by the physician to modify the patient's behavior? And the options are positive reinforcement, systematic desensitization, or it's a aversion therapy, or it's a flooding. I will just repeat, chronic alcoholic is then who was motivated to quit drinking and he was given disulfiram as you give normally. And which of the following was employed by the physician to modify the patient's behavior? It's a positive reinforcement, it's a systemic desensitization, or it's a aversion therapy, or it's a flooding. Anyone wants to try at least? Okay, I will just tell you the answer here is it's C. That is if you give a disulfiram in case of alcoholic, it behaves as a aversion therapy. Aversion therapy, basically you are giving a punishment, that is See, I'll just tell the definition which is given here. Basically, it's when a noxious stimulus or punishment is given after a specific behavior, the behavior is eventually inhibited. So it is used in treatment of alcohol abuse, paraphilias, and opioid addicts. So yeah, basically, so we use as disulfiram in alcoholics because it's an aversion. It's an aversion therapy. So yeah, so disulfiram is a positive reinforcement. Say positive, it will be when you tell and he gets motivated and he lifts. But when you give a drug like disulfiram, so then you can tell it's a aversion therapy because you are giving a punishment at it. It's a very noxious substance for the body, that's why. So yeah. Next we have, which of the following statements regarding the elimination and eradication of lymphatic filariasis is true? It's a big one. Yeah, it's which of the following statements regarding elimination and eradication of lymphatic filariasis is true? Options are: it will be considered as eliminated when number of microfilia carriers are less than 5%. I will repeat only once. It's a big one. And option B, it will be considered as eliminated when children born after initiation of the program are free from antigenemia. Then C, that is India has set the target of eliminating lymphatic filariasis by 2025, or it's a WHO recommends dual therapy with diethyl caramazine and albendazole for elimination of transmission. So yeah, if you don't know then it's okay, but yeah. So which are the following regarding the elimination and eradication of lymphatic filariasis is true? I'll just tell the answer. It's a big question. So yeah, which is true is basically it is considered as eliminated when the children born after the initiation of program are free from antigenemia. So yeah, it's a PSM question. You have to in PSM. I also don't like. If you like the subject, is very good for you. So yeah, it is basically it will be considered as eliminated when children born after initiation of program are free from antigenemia. That is regarding the elimination and eradication of lymphatic filariasis, which is true. See, and yeah, that's all for you. Next we have, a lady comes to you with a vascular injury to the inferior frontal gyrus. So which functional area is likely to be affected? And the options are motor speech area, Burnet's area, auditory area, or it's a visual area. So I repeat, I think when you know this answer, it's a lady who comes with vascular injury to the inferior frontal gyrus. So which functional area will be affected here? And the options are motor speech area, Burnet's area, auditory area, or it's a visual area. Anyone? Just guess it out. If you don't know, it's an anatomy question. You might be knowing it, not be knowing. Okay. You don't want to tell, I think. So yeah, this is basically motor speech area, and motor speech area, you know, it's a Broca's area in the brain. So yeah, Broca's motor speech area is likely to be affected when you have a vascular injury to the, we are talking about inferior frontal gyrus. So yeah, there will be aphasia if you have a. Next we have, see, last 3 questions. So yeah, next we have, it's a 2-month-old infant presented with abdominal distension and increased irritability for 10 days. So physical examination, you show there is a jaundice, hepatomegaly, and boiled cabbage odor. So investigation were notable for elevated transaminase and succinyl acetone. So what is the treatment of choice? And the options are, it's a dietary restriction of phenylalanine, dietary restriction of tyrosine, nitisinone, that is NTBC, or it's all of the above. So yeah, if you can just tell me what is your diagnosis here. It's a case of 2-month-old infant, abdominal Burnet's. I think we're talking about last question. No, it's Broca's area. Yeah, Broca's area. So yeah, where I was, see here it is, it's a 2-month-old infant, abdominal distension, increased irritability for 10 days, and physical examination, usually there is a jaundice, hepatomegaly, and there is a boiled cabbage odor. So just tell me what your diet, and the investigation will be notable for elevated transaminase and succinyl acetone. So yeah, just tell me what your diagnosis, if you can tell, otherwise you won't know all this. Total treatment of choice you won't be able to get, but what your diagnosis? Anyone? Okay, now see, the diagnosis here is basically it's a tyrosinemia. So yeah, I know it's a difficult one, but yeah, it's a type 1 tyrosinemia, that is tyrosinosis. So what is the treatment of tyrosinemia? So yeah, its answer is all the above. All the above, that is, there you have to, there will be dietary restriction you have to do for phenylalanine. You also have to, because it's a tyrosinemia, because so yeah, that's tyrosinemia. So yeah, because of that you cannot, there is a dietary restriction of tyrosine also you cannot give. So you cannot give tyrosine, you cannot give phenylalanine, and nitisinone also you cannot give. Only you have to get a drug of choice. So yeah, so the answer is all of the above. So all of the above is the right answer. So yeah, an odor resembling boiled cabbage resulting from increasing methionine metabolism can be noted. So it's a very characteristic for tyrosinemia. So yeah, next we have a 11-year-old child presents with pruritic lesion as shown. So which of the following is a drug of choice for this condition? So I'll just tell what is a, it's a image based question. I'll just tell the diagnosis, otherwise you won't be able to tell. Okay, diagnosis here is, it's a tinea capitis. So yeah, so it's a case of tinea capitis. So can anyone tell what is the drug of choice for tinea capitis? And the options they have given here is terbinafine and rhizophlavin, fluconazole, or it's a selenium sulfate shampoo. So yeah, if anyone can tell what is the drug of choice for tinea capitis: terbinafine, rhizophlavin, fluconazole, or it's a selenium sulfate shampoo. Anyone? Okay, I will tell that the answer here is B, that is rhizophlavin is the drug of choice for tinea capitis, and if that is not there, you can give terbinafine. Terbinafine is basically an alternate choice, but yeah, rhizophlavin is the drug of choice for tinea capitis, and you know it's basically in the head and all. Yeah. So yeah, fluconazole is given for M. canis, and selenium sulfate as the only supportive treatment, and orally you give that. That's all. So yeah, next question we have, it's a 4-year-old boy presents with facial edema that has now progressed to total body swelling involving the face, abdomen, scrotum and feet. So you do a urine analysis, it reveals protein, that is 4+, and serum cholesterol was also elevated. So what is the initial treatment of choice? So yeah, just tell me what is the diagnosis here. I'll just repeat, it's a 4-year-old boy, facial edema is there, and now progressed to the whole body swelling involving the face, abdomen, scrotum, feet, and you do a urine analysis, it shows protein 4, that is 4+ protein, serum cholesterol is also elevated. So what is the initial treatment of choice? Anyone can tell what is diagnosis here? Anyone, if you want to tell the diagnosis, because it's a case of, it's a child, that is pediatric, it's edema all over the body, cholesterol is high and protein is there. So yeah, I think you might be knowing, but you're not telling the answer. So yeah, it's a nephrotic syndrome. See, nephrotic syndrome, you all know it's in pediatric age group, and there is a all over the body swelling will be there, and then there is a hyperlipidemia will be seen, and what else is there? Serum cholesterol is high, that is hyperlipidemia you see, and proteinuria. Definitely you will see proteinuria in nephrotic syndrome. So yeah, what is the treatment of choice? Now at least, if you can, what is the treatment of choice for nephrotic syndrome? Prednisolone, cyclophosphamide, levamisole, or it's a cyclosporine? Anyone? I don't think. Okay. Yeah. So nephrotic syndrome, it's a very easy question. You have to remember it's a prednisolone steroid we get for nephrotic syndrome. So yeah, it's a minimal change. All that is classification is there, but yeah, prednisolone is the drug of choice for nephrotic syndrome. Initial treatment, yeah, that's all. Last question for today. Yeah. Okay. Last question for today. It's nephrotic syndrome is done. So yeah, last question for today. It's a 23-year-old prima gravida who underwent a cesarean section under spinal anesthesia, and it is administered by 22 gauge Quince needle. So 18 hours after the procedure, she complained of a headache which was aggravated by sitting up and relieved on lying down. So what is a definite treatment for the condition that she is suffering? So you have to tell a definite treatment, but before a definite treatment, just tell me what is the diagnosis again. So yeah, I will just repeat. It's a 23-year-old prima gravida, and she underwent a cesarean section under spinal anesthesia and was administered 22 gauge quinine needle, and 18 hours after the procedure she complains a headache, and which was aggravated by sitting up and relieved on lying down. So what is the definitive treatment for this? But what is the suffering, if you can tell this? Anyone? In anesthesia you might have been knowing this. In anesthesia we have, basically it's an adverse effect or a complication, you can tell. Okay, I will just tell the options if you can know by the options. What is the treatment of choice here? Analgesic, caffeine, supine posture, epidural blood patch. Anyone? Okay, I will only tell it's a case of post-dual puncture headache. Yeah, PDPH. It's a case of PDPH. So yeah, in PDPH what you give? See, analgesic, caffeine, supine posture and all that you can give, but it's all symptomatic treatment. So the definitive treatment is D, that is epidural blood patch is the definitive treatment here. So yeah, it's a case of PDPH, that is post-dual puncture headache. So yeah, we have to remember that all that. It's a second patch can be performed after 24 to 48 hours if needed. See, it's due to leakage of CSF, we know that. So yeah, 25 questions are over for today. So yeah, thank you so much. Take care and bye.